Euthanasia and physician-assisted suicide, can you even imagine teaching future medical students how to end their patients' lives? And the emphasis there is really, can you even imagine? What I was asking the reader to do, and of course the audience for this article is primarily clinicians but also clinical educators. And what I was asking people to do is to think about the consequences of having to teach physician-assisted suicide. If society decides to accept that, and if the medical schools are obliged to fulfill their new role, what will that mean? How will that be transmitted to a different educational program? And so the article was really meant to stimulate a discussion, a reflection on what that would entail. And it's interesting, there's really very little written in the medical education literature on euthanasia and its possible implications for education. First of all, we would have to have new modules teaching about death and the pathophysiology of death and how death occurs. We would have to have new sessions on the pharmacology of medications. And it's interesting, one of the articles I found in preparing for my article was a publication produced by the Joint Ministries of Health and Justice in the Netherlands, in Holland. As you probably know, physician-assisted suicide is legal in Holland. And this particular review, published in 2002, looked at how the law was enacted, how the law was being respected in Holland. And one of the recommendations is that that physicians should be further trained in the use of particular medications, such as morphine and benzodiazepines. So there was a recognition that the physicians didn't have sufficient knowledge of these medications. So that's a good example. And we would have to do the same thing here. We would have to train and prepare our future generation of physicians to meet the objective of physician-assisted suicide. And one of the ways in which medical schools have organized themselves, not every medical school, but many medical schools, have taken what's called a competency-based approach to teaching. In other words, they select a series of competencies, and then they look at the knowledge, skills, and attitudes that are required to fulfill the competency. So, for example, one of the competencies in this new situation might be, is the physician competent at accelerating death? That may be the competency that we're talking about. In which case, the school would have to prepare itself to ensure that the physician has done the right number of procedures, or has observed the right number of procedures. So can you just imagine if in the future we ask our medical students, we look at the end of the year, have you assisted, or have you observed 10 physician-assisted suicides, or 5 physician-assisted suicides? It may be that the medical student may not be able to graduate unless he or she has observed 2 or 3 of them. So that kind of consequence, I'm not suggesting that it will happen, but it's the kind of thing that we have to think about. And clearly, in jurisdictions where physician-assisted suicide is legal, that kind of reflection is ongoing.
It's ongoing after even 10 years, and they still discover that it's not, the competency is not up to date.
Well, it's
right?
like anything else. I mean, a physician will not be equally competent at all the procedures that are required. So.
But the difference is now it's a matter of whether, there's no return back once you assisted someone or you used it in like a needle shot. There's no way back. You can't ask the patient how he's feeling because he's not there anymore, right? That's the difference, right?
Yeah, of course. No, it's true that these are very high-stakes procedures.
Yeah.
This is not just suturing an incision.
And just
the message that is vehiculated by this fundamental change in values. You see, one of the things that we pride ourselves as a profession and that we identify as one of the core aspects of the medical profession is that we take the primacy of the patient's well-being as fundamental. And one of the things that we teach, one of the golden rules that we teach our medical students is first do no harm. Primum non nocere, first do no harm. And I'm having a difficult time reconciling that, first do no harm, with the harm that can be the harm that can be done by teaching physician-assisted suicide. And one of the things that I tried to do in my article was to ask people to think about the consequences of having to teach it. One of the consequences of having to teach it is that you teach about a different use of medication. At the moment, we teach about, for example, the use of morphine to relieve suffering and to control pain. What concerns me is what is the fundamental message that it's sending to the students. I think it has the ability to corrupt the fundamental cohesiveness of our clinical method. And our clinical method at the moment is constructed so that we support people, we relieve suffering, we relieve pain. We don't at the moment teach accelerating death. And I think it has the potential to erode these fundamental principles.